Hi, hello everyone. Welcome to Dr. Ravichandra Official. Today we are going to discuss one more important topic which will come for essay in your final examinations, that is amyloidosis. It can be asked for 6 marks questions and 3 marks also in your final examination. So, what is amyloidosis? It is a group of diverse extracellular protein deposits which have common morphological characteristic, affinity for specialized dyes, and a characteristic appearance under polarized light. So, amyloids are diverse extracellular protein deposits. They have the common morphologic characteristic affinity for specialized dyes, and they have a characteristic appearance under polarized light. Amyloid was first described by Rokitansky in 1842, and the substance was named as amyloid by Verco, who is known as father of cellular pathology. And he considered that material was starch-like, and so he has mistakenly given a name amyloid. Actually, amylon means starch. So starch-like material. So amyloid, oid, like, starch-like, amyloid. Now coming to physical nature of the amyloid. It is amorphous, hyaline, eosinophilic, extracellular substance. Amorphous, hyaline, eosinophilic, extracellular substance, physically composed of fibrils of indefinite length, and the diameter will be 7.5 to 10 nanometers, and they are arranged in beta pleated sheets. So, physical nature of amyloid is amorphous, hyaline, eosinophilic extracellular substances composed of fibrils of indefinite length with 7.5 to 10 nanometers diameters, and they are arranged in beta pleated sheets. Based on the analysis, amyloid is composed of two main types of complex proteins. One will be the major component and the other will be the minor component. In all the amyloids, the major component will be fibril protein, which is comprise about 95% of the amyloid substance. And the remaining 5% will be non-fibrillar component, which includes P component predominantly. And there are several other different proteins which together constitute the remaining 5% of the amyloid. So, majorly it is fibril protein 95%, and non-fibril protein will be remaining 5%. In this non-fibril components, the main predominant component will be most of the times P component. So this is a picture showing a amyloid. So it has a amyloid fibril 95%, and the 5% will be non-fibril component, that is P component. If you observe the structure, it is like helical structure with a amyloid component, fibril component, and also non-fibril component, P component. And it is arranged in beta pleated sheets. You can observe the congruent molecules like the handle, and the diameter will be 7.5 to 10 nanometers of indefinite length. As I said in the definition, it they have the characteristic with specialized dyes. So stains for amyloid are multiple. Out of them, the commonest stain we use is regular stain is HND, and the specialized stains will be Congo red, thioflavin T, Alcian blue, Van Giesen stain, Lugol's iodine. Okay, so This amyloid will stain red with the Congo red dye, and it will give apple birefringence when it is kept under polarized light. It also stains with thioflavin T and Alcian blue and few specific antibodies. It stains yellow to brown with Van Giesen stain, which is a special stain. In fresh tissues, amyloid stains brown when added with Lugol's iodine, but it converts to blue on treatment with 10% sulfuric acid. So these are the stains for amyloid. This may come for 3 marks question also. Stains for amyloid: Congo red, thioflavin T, Alcian blue, Van Giesen, Lugol's iodine plus sulfuric acid. And it shows apple birefringence when seen under polarized light after staining with Congo red dye. And regular stain will be HND. It is amorphous eosinophilic substance, proteinaceous extracellular substance. So this I have shown in the tabular form. HND, it will be appearing like pink hyaline homogeneous or amorphous substance. Methyl violet or crystal violet, it will show metachromasia, rose pink appearance. Congo red is the special dye. With it, it will show pink to red color under light microscopy. And after staining with Congo red, if we see under polarizing light, it will show apple green birefringence. Thioflavin T or thioflavin S, and it will show fluorescence under ultraviolet light. And coming to immunohistochemistry, antibody against the fibril protein, it shows positive immunoreaction or immunoreactivity is positive. And on fresh sections, as I said earlier, treatment with Lugol's iodine and sulfuric acid, it will convert into blue color. With Van Giesen, it will be brown color. So this is a picture showing amyloid with using a special stain Congo red. All these are adipocytes, fat cells, and if you observe, there is circular positivity of amyloid with Congo red in color. Based on the localization of this amyloid, it is mainly divided into two groups. One is local and the other is systemic, localized and systemic. And based on the etiology, this systemic amyloidosis is further classified into primary and secondary. Primary amyloidosis will have AL protein and secondary amyloids will have AA protein. We will discuss one by one. First, we will discuss localized amyloidosis. Localized means local to a specific organ. In brain, it will cause senile cerebral amyloidosis because of the deposition of the amyloid A beta. Senile cardiac amyloidosis because of the deposition of atrial natriuretic factor AANF. Medullary thyroid carcinoma in thyroid because of the A-calcitonin. And in this picture, I try to explain what is going to happen. All of us know there is a cell, in that there will be cytoplasm, there will be nucleus, and there will be cell membrane separating the two cells. In the extracellular space, there will be a beta precursor protein entering into the cytosol, and with the help of alpha secretase and beta secretase and gamma secretase, there will be cleavage. Alpha secretase will break at alpha part, beta secretase will help in breakage at cleavage at beta part, and gamma secretase will help in breakage at gamma region. Cell with A beta protein will undergo partial proteolysis and results in formation of A beta peptide. Coming to systemic amyloidosis. As I said, systemic amyloidosis is mainly divided into primary and secondary. Primary amyloidosis will have AL protein, secondary amyloidosis will have AA protein. Along with this, few other entities have been recently entered. That is hemodialysis associated amyloidosis. That is, you will be able to observe the amyloidosis in frequently hemodialysis patients. It is due to the deposition of amyloid protein A beta to microglobulin. And there is familial amyloidotic polyneuropathy because of ATTR, transthyretin. Systemic senile amyloidosis also because of ATTR protein. Familial Mediterranean fever because of deposition of amyloid A associated protein, AA, amyloid associated protein. So we have discussed that it is mainly two types. One is localized and the other is systemic. And the systemic will be mainly primary and secondary. In the primary it will be AL and in the secondary it is AA. Now coming to etiopathogenesis. What happens in primary amyloidosis? In primary amyloidosis, plasma cells will secrete immunoglobulin light chains, which will undergo limited proteolysis to AL chains and amyloid AL and deposited in the tissues. Remember, primary amyloidosis, AL protein, limited proteolysis, immunoglobulin light chains. In secondary amyloidosis, chronic inflammation leads to the macrophage activation, which will secrete interleukins IL-1 and 6, which will activate the hepatocytes to secrete serum amyloid associated protein, which will undergo partial proteolysis to amyloid associated proteins and gets accumulated in the tissue. In some cases, proteins are misfolded because of the misproper communication or because of the wrong functioning of the chaperones, and they become insoluble proteins and get accumulated in the tissues as small oligomers. This is a beautiful picture showing the pathogenesis of amyloidosis. As I said earlier, mainly two, one is primary and the other is secondary. Both will differentiate at few points: at stimulus, at the soluble precursor protein level, in the partial degradation, in the accumulation of non-fibrillar component, and resulting in formation of insoluble fibrillar protein. So, coming to primary. Primary means the cause is unknown. It may be because of the multiple myeloma or B-cell lymphoma or other plasma cell dyscrasias, where there will be monoclonal B-cell proliferation, thereby activation of the plasma cells and B lymphocytes. Plasma cells will secrete excess immunoglobulin light chains. These light chains can be lambda and kappa chains, and these are excreted into the urine, which are called as dense zone proteins. In the macrophage, these immunoglobulin light chains will undergo limited proteolysis or partial degradation and resulting in formation of a component called as AL, amyloid light chain protein, AL amyloid. In secondary amyloidosis, it is because of the chronic infections, chronic inflammation, cancers, familial Mediterranean fever. Here, macrophages will get activated and they will release the cytokines. Cytokines are interleukin 1 and 6. These cytokines interleukin 1 and 6 will further activate the hepatocytes to secrete serum amyloid associate protein. Serum amyloid associate protein in the presence of amyloid enhancing factor AEF in the reticuloendothelial cells will result in formation of AA amyloid associated protein. For both formation of AL amyloid and AA amyloid, there will be helping of the amyloid P components, glycosaminoglycans also get deposited. Apoprotein E also gets deposited. Simply to remember, with a stimulus, there will be few cells getting activated and resulting in secretion of soluble precursor proteins which will undergo partial or limited proteolysis and resulting in formation of a non-fibrillar components which become which along with the soluble fibrillar components will is to form amyloid. So in primary it is multiple myeloma, plasma cells are involved, thereby macrophage gets activated and there will be partial degradation and formation of amyloid light chain AL amyloid. In secondary amyloidosis, chronic infections will result in activation of macrophages which will release cytokines interleukin 1 and 6. These will activate the hepatocytes, and after activating the hepatocytes, they will release amyloid enhancing factor into the reticuloendothelial cells and thereby resulting in the formation of AA amyloid with the deposition of amyloid P component and glycosaminoglycans and apoprotein E. Primary third alphabet will be I. So immunoglobulin light chains are involved. The pathogenesis main is immunoglobulin light chains, AL protein. Okay. Secondary amyloidosis. Third alphabet will be SEC. C. Remember, chronic infections. Cytokines activated. Okay. Clear? Now we will discuss the morphology. Under the morphology, there will be gross features and microscopic features. As I said, it is a localized or systemic amyloidosis. What are all the changes that are going to happen in the heart? We will first see. In any organ, if there is amyloid, there will be enlargement of the target, mildly enlarged and firm in consistency. Heart will be. And the amyloid will be deposited in the subendocardium and interstitial tissue between the myocardial fibers. In the liver, as I said earlier, wherever amyloid gets deposited, there will be enlargement of the organ. The liver will be moderately enlarged, and when we cut it into two bits, on cut surface there will be waxy appearance, and the amyloid is first deposited in the space of disc, followed by the involvement of sinuses and hepatocytes. This is a beautiful picture of showing the liver tissue. How you are going to identify a liver tissue? There will be a central vein and a portal triad. With that, we can confirm it as liver tissue. And this amyloid deposit will be first in the space of the disc, then followed by sinuses. So amyloid gets deposited in the space of disc. And in the B picture, you can see Congo red stain, and it is kept under polarized microscopy showing the apple green birefringence wherever amyloid is deposited. Now coming to spleen. After the heart and liver, The amyloidosis can also happen in a spleen. Spleen will be moderately markedly enlarged. Moderate to markedly enlarged. And this amyloid deposition will be, it can be in splenic follicles or splenic sinuses. If the amyloid is deposited in splenic follicles, the deposits will be seen as tapioca seeds or sago on gross examination. And if they are deposited in the red pulp in the splenic sinus, the spleen will be very large. So, amyloidosis in spleen can result in sago spleen or lordaceous spleen. This sago spleen and lordaceous spleen, you can get it in 3 marks questions also. So, you have to write amyloid deposited in splenic follicles will result in enlargement of the spleen, and there will be tapioca-like seeds appearance on gross examination. So it is called as sago spleen. And if this amyloid is deposited in splenic sinuses in red pulp, it is lordaceous spleen, very large spleen. So this picture is a showing red pulp and white pulp. All the white pulp will be most of the time atrophied and the red pulp will be expanded. In between the, you will be appreciate the amyloid deposition. It can be in the sinuses or follicles. The amyloid will be pink, acellular, homogeneous, amorphous, extracellular, proteinaceous, pink eosinophilic substance. And it can be stained with Congo red, and and it stains red with Congo red, and under polarized microscopy it will show apple green birefringence, which is the characteristic feature of amyloid. Now, after the heart, liver, spleen, the organs involved is kidney. Kidney is mildly enlarged and has waxy cut surface. Amyloid primarily deposited in the glomeruli and rarely in the interstitium and renal blood vessels. So the main part involved in kidneys are glomeruli. So this is a picture showing the deposition of the amyloid in the glomerulus. At places there is deposit in the interstitial vessels also, and you can be able to see the amyloid cas or protein cas. So with this, our main topic of amyloidosis is completed. This primary amyloid and secondary amyloid differences can be asked for 6 marks questions or sometimes 3 marks question. So what are the differences between a primary amyloid and secondary amyloid? The primary amyloid can be differentiated from a secondary amyloid under 8 features. One is biochemical composition, second is associated diseases, third it differs in pathogenesis, incidence, age, course and prognosis, organ distribution, and the stains to distinguish. Primary amyloid, as I said earlier, it is light chain proteins, AL, and the light chains can be lambda or kappa. Lambda chains are more common than kappa. In this primary amyloid, the feature is there will be sequence homology of the chains. Whereas in secondary amyloid, it is amyloid associated proteins AA, and they are derived from large precursor protein serum amyloid associated protein SAA. So there will be no sequence homology of the polypeptide chains in secondary amyloid. Coming to associated disease, as I said, it is light chains and plasma cells are activated. It is seen in plasma cell dyscrasias like multiple myeloma, B cell lymphomas. And secondary amyloidosis is seen most of the time in chronic inflammations, chronic infections, TB, leprosy, osteomyelitis, bronchiectasis, autoimmune diseases like rheumatoid arthritis, cancers like RCC, renal cell carcinoma, Hodgkin's disease. Coming to pathogenesis. In both primary amyloid and secondary amyloid, there will be stimulus. That stimulus can be because of the associated disease. Here in primary amyloid, monoclonal B cell proliferation will occur, whereas in secondary amyloidosis, chronic inflammation will enhance the amyloidosis. As a result of monoclonal B cell proliferations, plasma cells will secrete excess of immunoglobulin and light chains. They will undergo limited proteolysis or partial degradation and results in formation of insoluble AL fibril. Remember, primary alphabet I immunoglobulins. In secondary, it is SEC C. So chronic inflammation will result in formation of activation of the macrophages, thereby release of cytokines IL-1 and IL-6, interleukin 1 and 6, which will undergo partial proteolysis and result in formation of amyloid enhancing factors, thereby resulting in formation of insoluble AA fibrils. Incidence: primary amyloid is most common in US and other developed countries. Secondary amyloidosis is most common worldwide, but particularly in developing countries. So primary is seen in developed countries, secondary it is in developing countries. Age will be: primary amyloidosis is seen in adults more than 40 years, whereas secondary amyloidosis, it can happen in any age, including the children also. Course and prognosis: it is rapid and progressive and dismal prognosis in primary amyloidosis, whereas in secondary amyloidosis, it is better. You can treat it by treating the underlying cause. Organ distribution will be: in primary amyloidosis, mainly kidney, heart, bowel, and nerves, whereas in secondary amyloid, kidney, liver, spleen, and adrenals. Stains to distinguish: there will be Congophilia. Philia means loving. So the amyloid is loves Congo stain. So it will take the stain and appear red. And this Congo red color will be continued even persists even after treatment with permanganate solution. And the specific immunostains like anti-lambda and anti-kappa can also be useful to differentiate a primary amyloid. This Congophilia will disappear after permanganate treatment of the sections in secondary amyloidosis, which is a key point to differentiate primary amyloid and secondary amyloid. And the specific immunostain is anti-AA. Okay, with this, our topic amyloidosis completes. Thank you for patient listening. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos.